pipeline healthcare workers in the Department of General Practice and Emergency Medicine of Dhulikhel Hospital with an educational video on oxygenation strategies in a COVID-19 patient. We hope that this video will be beneficial for the multidisciplinary healthcare personnel involved in managing COVID-19 patients in urban and rural settings. Now, let's dive right into the video. In this educational video, we will be covering the following topics. Firstly, we will provide brief overview of various oxygen delivery systems, followed by a guide on how to initiate and titrate the oxygen delivery to the COVID patients, various oxygen sources, and finally, review the functionality of non-invasive positive pressure ventilation.
We would like to highlight the need of self-protection with appropriate PPE for aerosol precaution. Studies have demonstrated that any oxygen delivery modality can generate aerosol and can pose risk to the environment. Even nasal cannula is aerosol generated. As shown in the figure, wearing a well-fitted surgical mask below or above the oxygen delivery interfaces can reduce aerosol transmission. Also, we should turn off the device before removing any device from the patient. Now, let us understand, when does a patient require treatment with supplemental oxygen? The treatment with supplemental oxygen is required if the saturation is less than 90% even without respiratory distress. Please note that WHO has set this saturation threshold only during crisis situations like the one we are currently experiencing. The next indication is saturation less than 94% if pregnant or if ABCD emergency signs are present. For ABCD emergency signs, look for presence of severe respiratory distress, cyanosis, or increased respiratory rate, which are AB signs, increased capillary refill time, tachycardia, or low blood pressure, that is C signs, and altered mental status, that is D signs. However, the most readily accepted indication for supplemental oxygenation in non-crisis situation is decreased levels of oxygen in the blood to achieve oxygen saturation levels based on pulse oximetry with a target level of 94 to 96% in most or 88 to 92% in people with COPD or other lung diseases. Common oxygen sources are pipeline intra-hospital distribution networks, oxygen concentrators, and oxygen cylinders. First, let us talk about pipeline intra-hospital distribution networks. They are supplied from a central source through pipelines. A flow meter and a humidifier are connected and oxygen is delivered to the patients. It is important to remember to refill the humidified chamber with distilled water. The advantages of these pipeline networks are they can be cost-effective for large facilities and is a continuous supply of oxygen. However, its limitations are it requires high capital investments, uninterrupted power, needs adequate infrastructure and high maintenance for piping, requires backup cylinder supply, and there is risk of gas leakage from the piping system. Oxygen concentrators. An oxygen concentrator is a self-contained, electrically powered medical device designed to concentrate oxygen from ambient air. It uses PSA technology, that is pressure swing adsorption technology, to draw in air from the environment, removing the nitrogen to produce a continuous source of more than 90% concentrated oxygen. It provides low flow, typically 1 to 5 liters per minute. It should not be used if the oxygen concentration of the patient falls below 82%. The advantages of these oxygen concentrators are continuous oxygen supply at low running cost if power supply is available. Also, the output flow can be split among multiple patients using a single oxygen concentrator. The limitations are low pressure output. Therefore, usually it is not suitable for continuous positive airway pressure, that is CPAP, or ventilators. Also, it requires uninterrupted power supply and backup cylinder supply and maintenance. Next is oxygen cylinders. The most common source of oxygen storage used in healthcare settings is an oxygen cylinder. These cylinders are filled at a gas manufacturing plant and then transported to health facilities. The various parts of an oxygen cylinder are the cylinder, a pressure regulator, a flow meter, and humidifier. Various types of cylinders are available from type C to J. Their dimensions and capacity are shown in the picture. Oxygen cylinders contain oxygen under pressure, and the pressure gauge displays the level which gradually falls as the cylinder is depleted. When the valve is turned on, the full pressure is typically about 2200 psi, that is pounds per square inch, even though the size and subsequent capacity of the tank may vary. This is shown by the green section as shown in the picture. When the needle gets to the lower part of the red section on the gauge, it means it is time to change the cylinder, that is around 200 psi. As you can see in this picture, this is a flow meter with an oxygen inlet, flow control valve, and a labeled flow meter tube. A float ball bobbin is present inside this flow meter tube, which denotes the level of oxygen being delivered to the patient. The maximum flow rate regulators give 15 liters per minute. Here is a simple formula for which the remaining cylinder pressure is noted. We will need to take off a residual pressure of around 200 psi, which will allow some errors in calculation or initial cylinder fill errors and give a short extra supply. Then we require the cylinder constant, also known as the cylinder conversion factor, as shown in the text at the side. The various cylinder types have their specific conversion factors. These are set figures we will need. And then finally we need the flow rate required for the patient. Then using the formula of the remaining pressure minus 200 psi times cylinder conversion factor whole divided by the flow required, we can calculate the duration of flow in minutes. If we require a flow rate of 6 liters per minute using an E-type cylinder, which is a common type used for portable cylinders, we have to check the remaining psi in the pressure gauge regulator. In this picture, we can see that the remaining pressure is 1500 psi. Now, subtracting the safe pressure of 200 psi, we multiply 1300 times 0.28, which is the conversion factor of an E-type cylinder. Then, the whole is divided by 6, which is the flow rate required for our patient. And it will come to be about approximately 1 hour. They require no power source. However, the limitations are they require transport or supply chain. It is an exhaustible supply, highly reliant upon suppliers. There's risk of gas leakage and unwanted relocation.
Before learning about oxygen delivery methods, let us understand what FiO2 is. FiO2, or fraction of inspired oxygen, is the concentration of oxygen in the gas mixture. The gas mixture at room air has FiO2 of 21%, meaning that the concentration of oxygen at room air is 21%. FiO2 depends upon the delivery method chosen, flow of oxygen, and respiratory pattern of the patient. If the patient has only mild respiratory distress or low oxygen saturation but is breathing rather comfortably, we can provide oxygen via nasal prongs. Nasal prong is a hollow tube with 2 prongs inserted into the nostrils and secured in place by hooking it behind the ears, and the other end connected to some oxygen source. We need to apply a surgical mask over the nasal cannula to minimize aerosol dispersion. The oxygen source should be turned off before application and removing the nasal prongs. Nasal prongs deliver oxygen at 1 to 6 liters per minute, which can increase the FiO2 to 25 to 40%. If more than 6 liters per minute is delivered, it can cause dryness of the nasal mucosa. Nasal prongs are cheap, comfortable, and easily tolerated by the patients. Patients are not rebreathing their own exhaled air and are able to speak easily while on this device. However, they can be easily dislodged, and the effectiveness is dependent upon the pattern of breathing, since the patients can still breathe air through their mouth, altering their FiO2. So we need to encourage the patient to breathe through their nose at all times. Even if after reassessment and serial titration of oxygen up to 6 liters per minute, the target saturation of oxygen is not achieved, or if the patient is in severe respiratory distress, decide to use a simple face mask. In the simple face mask, the oxygen tubing is connected to the plastic port at the bottom of the mask. The open side ports in the mask allows air to mix and dilute the oxygen, as well as allows way for the expired carbon dioxide to leave. The mask can be molded over to fit the patient's nose and mouth and is secured by elastic band at the back of the head. The flow rate should be adjusted between 6 to 10 liters per minute and titrated depending upon the target oxygen saturation. Simple face mask delivers FiO2 of 35 to 60%. However, it is difficult to know exactly how much oxygen is being delivered through a simple face mask. A point of caution for face mask is it is not to be used in flow rates less than 6 liters per minute, because this will lead to rebreathing of the expired carbon dioxide, which is detrimental to the patient. Also, a simple surgical mask is to be applied over the face mask to minimize aerosol dispersion. If the patient deteriorates or has arrived in a critical condition, a non-rebreather mask can be used to deliver high concentrations of oxygen to the patient. The non-rebreather mask has an attached reservoir bag and a one-way valve, which will allow the escalation of FiO2 up to 90 to 100%. The oxygen tube is connected and the flow rate is adjusted between 10 to 15 liters per minute. The valve between the face mask and reservoir bag needs to be pressed in order to fill the bag up before application. It should be adjusted to fit over the patient's nose and mouth, similar to the previous face masks. Also, an elastic band can be used to attach the mask to the back of the head. The non-rebreather mask has a one-way valve that prevents rebreathing of expired air, and a surgical mask should be placed above it. A note of caution during scarcity of oxygen is that since a higher flow rate is needed in non-rebreather masks, consider quick escalation to the use of non-invasive ventilation devices like BiPAP or CPAP machines if available, as this may help save oxygen and save more lives. Non-invasive ventilation cannot and does not replace invasive ventilation, but evidence shows that non-invasive ventilation can be used in many situations to decrease patients' dyspnea and worker breathing, improve gas exchange, and ultimately avoid the need for intratracheal intubation. However, if the patient is drowsy, not able to protect his or her airway, and does not have spontaneous respiration, advanced airway is warranted. Close monitoring of GCS, patient's respiratory effort, blood pressure, and saturation is necessary when on non-invasive ventilation. The application of BiPAP or CPAP is uncomfortable to the patient. Therefore, proper explanation is counseling is mandatory before non-invasive ventilation. We are demonstrating the device available at our emergency room. This is the device with its parts: power source, humidifier chamber, connecting tube, the oronasal mask with expiratory valve, and the port for oxygen connection. Most of them require an electrical power source. The humidifier of the machine should be filled with distilled water up to the level mark given. The device should be set pre-hand, and then only the mask should be applied. For further detailed explanation regarding how to set the various pressures of BiPAP and CPAP, please follow the link given. We need to make sure that we select a proper sized oronasal mask for the most effective ventilation. The mask should be applied and the straps should be properly placed behind the head. After starting the device, we should check for fit and find if there are any air leaks. The patient should be counseled and advised to breathe together with the device. As there are expiratory valves, the surgical mask needs to be applied over it. What can be done if there is drop in saturation or there is increasing respiratory rate? Here are some points. First, we should make sure that the oxygen supply and all the equipments are working properly. We should check if the cylinder has sufficient oxygen Check that the oxygen is flowing out from the prongs or masks by holding the end close to our hand. We should check if there are any leaks in the connection or in oxygen tubing. We can increase the flow or delivery method, and we can try proning if possible. If wheeze is present, we can give salbutamol to the patient with spacer. 8 puffs equal 1 nebulization. After starting the patient on oxygen, we should frequently monitor the response of the patient. If the response is not adequate, we escalate the oxygen therapy. Titrating oxygen will improve patient condition and also save oxygen. We should escalate the therapy if there is continued distress or the saturation is less than 90%, or if the saturation is 94% in a pregnant lady, or less than 94% if there are any emergency signs. First, we start with oxygen at 5 liters per minute using the nasal cannula. If there is no adequate response, we use face mask and increase oxygen to 6 to 10 liters per minute. Even so, if there is no adequate response, we can use face mask with reservoir bag and start oxygen at 10 to 15 liters per minute. Here, we should ensure that the bag is inflated. Even if there is no adequate response, then we can start the patient at CPAP, BiPAP or high-flow nasal cannula if there is adequate oxygen supply. Also, we should try to find a high level of care for the patient. Now let's discuss on what to do if the patient is stabilizing or improving. We can start with decreasing the oxygen flow by 1 to 2 liters per minute and observing the patient for 2 to 3 minutes. If the patient does not tolerate less oxygen, then we should not titrate oxygen flow until the patient is more stable. If the patient tolerates less oxygen, then we should recheck the patient in 15 minutes and measure oxygen saturation. If the patient remains stable and oxygen saturation is greater than 90%, we should continue to titrate the oxygen as tolerated by decreasing the flow by 1 to 2 liters per minute. Then we set the lowest possible FiO2 and observe the patient. Here we have discussed on various oxygenation strategies for COVID-19 patients, from self-protection of healthcare workers, indications of oxygen supplementation, various oxygen sources, various oxygen delivery methods and how to use them, rules for oxygen troubleshooting, oxygen escalation and de-escalation therapy. Hope all this information was useful and will help you in taking care of COVID-19 patients. Thank you.